So welcome everybody to this webinar series with HMPF and Migraine Meanderings. We're going to be talking about the results of our survey that we recently did with patients on combination therapy for migraine. And we're very excited to present these results to you. They're really interesting. And so we're just going to get going on that right now. Just to let you know that this is the second in our series this year. Our first patient survey we did was on the emergency room experienced patients. Our next one that will be starting in October is going to be on devices. And then after that, we're going to cover that hot topic of step therapy. But for right now, let's get talking about combination therapy. And Lindsay, I'm going to hand it over to you to talk a little bit about HMPF.
Sure. Thank you, Shoshana. And thanks to everyone for joining. So a quick level set for folks who don't know, I'm Lindsay Vitiniaks. I'm the Executive Director of the Headache and Migraine Policy Forum. We're a Washington, DC based 501c4 group coalition of stakeholder members. We have approximately 24 members that really seek to work on the niche area of policy and access for the community. So, you know, we see ourselves and our members as sort of quarterbacks for a lot of the patient engagement and the work that Shoshana does, especially with her group. And so, you know, I'll let Shoshana talk about migraine meanderings, but HMPF is also undertaking right now a claims data project that is very close to and almost parallel and complementary to the input that Shoshana has received from her group. We are doing a cost benefits analysis using claims data from 2021 for migraine patients. It's a longitudinal data survey, but it's reliant solely on claims data, whereas we think that this project that Shoshana has helped undertake provides sort of the patient real world lived experience. So as we know, when we're talking to policymakers, other decision makers, having that sort of hard data, maybe the clinical data, but then also the lived experience, real world on the ground patient experience information is critical to help make that sort of public affairs case, if you will. And so we're just excited to help on this project and partner with Shoshana. Thank you.
Yeah, so my name is Shoshana Lipson. For those who don't know me, I'm the Executive Director of Migraine Meanderings, which is a 501c3 nonprofit. Our mission is to provide patient-oriented resources, encouragement, support, and education for people who live with migraine disease to raise public awareness about this disease. And the thing that I'm really passionate about is to empower patient voices. And part of that empowering patient voices is to make sure that we hear back from patients about what the real world experience is. And patient centricity is such a hot topic nowadays in the healthcare system. But what it really means for us as patients is that our voice is heard and that it is acted upon. And so we love it when patients participate in these surveys. We can take this data and we can utilize it to help elevate the patient voice. That is such an important thing. And so that's what we are doing with this particular survey. I love co-branding these surveys with HMPF because they deal with the policy side of things, which is not my specialty at all. We are able to hear the patient voice and interact with the patients. And so we work really well together on this, and it's a total pleasure to be working with you, Lindsay, and with your team. So thank you for this opportunity as well. So let's get going on this survey, and we're going to start off with some brief demographics from the survey. So we had 516 people participate in this patient survey. We ran it for a whole month. It was in the month of July. No surprise here, when you look at gender, you're going to see that 95% of the people who participated were women, 3% were men, 2% were other. For our health insurance coverage, 67% of people said that they had commercial insurance, 33% said they had Medicare, Medicaid, TRICARE, any kind of government funded insurance. 10% said other. We did have a few people from other countries, and so that could also be part of that number, or maybe people who are uninsured as well, or people who weren't sure that they had commercial insurance. And then looking at age, you'll see that the largest percentage of people we have are between that age of 26 to 55, which is not surprising. When you go younger than that, 25 down, only 4%. So we can see that that's a gap that we really need to try to reach out to, that college age, young adult age, where it's so important for people to have appropriate treatment for migraine in those early years. And then as you get older as well, so only 18% are 56 to 64. And then once you get 65%, that's only 7%, which again is another area that we really need to reach out to, because we know that for many people, migraine do not stop after that magic age of 65. No matter what we've been told by doctors, it's not kind of a magic switch off point for so many people. And so we need to be able to reach out into that older community as well, because their voice is so important to be heard. Now, looking at migraine frequency, as before with our surveys, and we expect this to continue, is that we see that it's heavily skewed towards people who have chronic migraine. So that's 15 days or more per month of headache and migraine days. Only 25% were 8 to 14 days a month, and 16% were 1 to 7 days a month. So that's not a big surprise, because generally as people get sicker with migraine, they're more likely to be online, they're more likely to feel that it's important to have their voice heard. However, obviously, this is another area that we want to figure out how to reach out into the community of people who have low frequency episodic, especially, so that we can start to hear their voice as well, which again is so important. Now, when we get to treatment, 100% of the respondents to the survey took at least one preventive and or abortive treatment for migraine attacks. So that's a little bit of a, not necessarily very helpful data, but we just know that basically everybody who took this survey was taking a medication for something. It doesn't mean obviously that everybody was taking a preventive, but they were all taking some kind of medication for migraine attacks. 65% said that their doctor have discussed different treatment options to create a personalized treatment plan and are open to new options. However, what I think is surprising there is that being 35% do not believe that their doctor have discussed different treatment options. And obviously, that is an area of concern where we want to make sure that the patient voice is elevated, that as patients, we know that we are, that it's appropriate to have a partnership approach in our treatment plan. And that is really important. I just want to remind you as we go through this, as Lindsay just wrote the comments, please put your questions in the Q&A, and we will get to those questions at the end of this webinar as well. Moving on to preventive treatment specifically. So this is where the numbers get really important. 71% of respondents have been prescribed more than one preventive treatment. Now, if we go back and we were to look at how many people have chronic migraine versus how many people have episodic migraine, we would still expect that more people would be on a preventive treatment. But we're pretty close to the numbers where they would be. 42% said that on their treatments, their migraine attacks decreased. So that means 58% said that their migraine attacks did not decrease, which means they are not receiving optimal treatment for their migraine. 22% experienced a 25% decrease, 16% experienced a 50% decrease, 10% experienced at least a 75% decrease. And I know that in my groups, we always have those amazing people who are super responders who have, anywhere from 80 to 100% decreases, like the migraine attacks just magically seem to stop when they're on the right treatment for them. That may not last permanently, but for as long as it lasts, it's an amazing experience. And we do talk about those people as super responders. And if you're one of those people, you know how amazing that is. Then going on to abortive treatments, 75% of respondents have been prescribed more than one abortive treatment. This is where we're starting to look at the nitty-gritty of some of the combination therapy issues. So about 55% have been prescribed fast-acting medications to take if regular oral medications aren't working or presenting side effects. And this is an interesting statistic because we see so many people with migraine end up in the emergency room, which is what we talked about in our last patient survey. And one of the reasons, obviously not the whole entire reason, but one of the reasons is that so many patients are not prescribed fast-acting medications. So we're looking at nasal sprays, we're looking at injections, something that's going to get into your system quickly, especially if you have extreme nausea, you have gastroparesis, or you're vomiting. If you take an oral medication and you vomit immediately afterwards, the immediate question is going to be, has this medication even gone into my system? Is it safe to take another dose of it? And so these fast-acting medications, which are now available for patients, are appropriate to be prescribed to many of those patients who have not already been prescribed that. And that's a conversation that patients can have with their doctors. Going on to treatment reduction, and then I'm going to hand this over to Lindsay. So 44% of those who use a combination of preventive treatments say that the severity of their migraine attacks has decreased. So that's great that 44% say that their attacks have decreased. Obviously, we can see immediately there's a huge treatment gap. It's wonderful that there are treatment options in the clinical pipeline, because that still means that 56% of people who use a combination of preventive treatments say that the severity of their migraine attacks has not decreased, and it has not reduced the number of abortive medications needed. So if we're going to break those numbers down a little bit, you'll see that 23% experience a 25% reduction, 16% experience a 50% reduction, 10% experience a 75% reduction or more. And again, then we're getting into the super responder level, those amazing people who have just had this incredible reduction in migraine and have really got their lives back. So I'm going to hand it over to you, Lindsay, to talk about barriers to medication access.
Thank you, Shoshana. And it's not that you get the good news and then I get the bad news, but this is how we...
It seems like that, right?
Well, we have good news at the end, I think. So, you know, for Shoshana, you just heard that data reinforces just how combination therapy is working for migraine patients. But the unfortunate bad news is that insurers have not recognized that in practice. They have still deemed, in terms of access, combination therapy in part experimental, which, you know, I think as we were all going through ICER, we sort of would not chuckle, but we would say, you know, for migraine patients, the name of the game has always been combination therapy, whether it's trying something in the migraine toolbox. It's never simply sort of one thing that may work for folks, and for all people, it is having sort of that combination of approaches that might be the best way to manage their disease. And so the survey reinforced all of this. We saw that 68% of respondents experience insurance issues accessing the combination of medications. I can say firsthand, as a group that has battled with some payers and hearing their feedback that it's deemed experimental, that's something we've heard, even though, you know, you have clinicians who are pointing to the patient file saying, look, we're reducing the number of attacks. It's extremely frustrating. 38% indicating that the inability to access that combination therapy then impacted their ability to manage their disease. And we know this is a progressive disease where you could tip the scale from a certain number of days into a far more disabling prospect. And so that's very troubling. And then 41%, of course, say that this inability to access combination therapy has meant missed work, less, you know, presenteeism issues, missing out on special moments with family, all of those sort of hidden or invisible costs to the disease and under suboptimal treatment of the disease. Next slide. So here we have the sort of demographic profile of the respondents. This is a really great snapshot of the types of therapies that this group of 516 patients, you know, what therapies they are utilizing. So that might be, you know, 68% were prescribed a monoclonal antibody in combination with at least another preventive, 60% with a botulinum neurotoxin in combination with another preventive, and then 65% a botulinum neurotoxin with a prescribed abortive. And also within this group, 54% prescribed multiple CGRP inhibitors for preventive and or abortive treatment, understanding that those may work complementary to one another. And then less than 22% had ever received preventive medication through IV infused therapy in combination with another drug to prevent migraine. And of course, you know, part of this with insurers that there's a chilling effect, right? So it becomes simply so onerous for, you know, a clinician to perhaps, you know, keep thinking about prescribing something when our messaging is please just keep trying, because it is so important that a patient goes through this journey to figure out what works for them. And that may be infused therapy in some cases. So next slide. This is a bar graph that talks a bit about sort of, and maybe the trickiness of some of the questions, but lays out for folks, when they've received denials and what those denials came from. I will note that we have the sort of darker gray bar at the bottom, CGRP, monoclonal antibody, and another preventive. And then at the very bottom, you have a question of a botulinum neurotoxin and another preventive. Those numbers could actually be higher based on what a person, and Shoshana and I were talking about this before today's webinar, but how that individual respondent classified their preventive in that scenario. So we actually think those numbers are perhaps undercounted in a way, but you can still see it's a sizable number of folks who are receiving an innovative therapy and having issues in combination with something else. So now I will turn it to Shoshana for perhaps the most important part of the survey, which is sort of the human impact and toll.
Sure, absolutely. And I think just to clarify, and I apologize, I should have said this at the beginning, but a lot of the time when we think about combination therapy, especially when the monoclonal antibodies first came out in 2018, we were looking predominantly at combination therapy between the botulinum neurotoxin and the monoclonal antibodies. So we were hearing a lot that insurance companies wouldn't cover both of those. So that was a really hot topic. But in this survey, we're going beyond that. We're not just looking at that. We're looking at any type of combination therapy. So that's preventive and preventive. It's preventive and an abortive. We're still hearing some doctors who will not prescribe an abortive on top of a preventive, or insurance companies that don't understand you need both the preventive and abortive. And then for people who need more than one abortive, so we're looking at the fast-acting rescue medications on top of an abortive that you may use for the beginning of your attack. And then, of course, we've got the hot topic of medical devices, which we're going to be covering more in depth in the next survey. But to hear back from the patients, this is really interesting just to see what people are saying. So one person says, although insurance has denied treatment and medications, I'm often able to access them via coupon programs. So I'm still able to get the care that I need. And I think that that's really important to know. Obviously, those people are on government-funded insurance. They can't use these coupon programs, although many companies do have patient access programs that some of the people on government-funded insurance can utilize. The other challenge, of course, is what happens when those coupon programs run out, or when they're not providing as much back. And so there's often a lack of information given to patients about the importance to pursue insurance coverage while they're utilizing the coupon program, because that's not an evergreen program in most cases. Another patient said, after an initial rejection, the doctor appealed. I was able to get the medications I needed. The delay was not fun, but the issues were resolved. And that's a fabulous example of you just got to appeal. Again, many people think that because insurance has denied something that is it, but you can appeal against insurance. You can appeal again. We are finding that some HCPs don't even want to go down that process. They'll say the insurance is going to deny it. And then we hear patients telling us, my doctor says, don't even bother trying. And that's just the opposite of what we tell patients. We tell them, be empowered, fight your insurance so that you can get the treatment that you need. Then we're looking at, this person talked about step therapy, which we're going to be looking at in 2 surveys time. Just says that was a huge barrier, as was my doctor's unwillingness to mix CGRP preventives with CGRP abortives. There is now some clinical data that's looking at that, but when the CGRPs first came out, this obviously was a very hot topic. Is it even safe to mix those two? And part of that issue is that so many doctors are not certified in headache medicine, and there are a lot of ways that they can, I shouldn't say there's a lot of ways, but there's different ways you can get certified in headache medicine, obviously through the UCNS, but also through the National Headache Foundation. They have their AQH program. And so there are ways that doctors can be educated in that. And then there are other just CME courses they can take so that they can be current with what is going on. Dealing with insurance is like playing roulette. I like this comment myself. You have lots of numbers and you just hope that the ball stops on your number. And that really is what it feels like with insurance sometimes. And honestly, it's exhausting. keep just kind of running that ball and hoping that it stops on your number. Another person says, thankfully, my doctor and I are constantly going up against insurance and have gotten things approved. So again, that's the case. You have to keep going up against insurance, and it's exhausting. It's not only exhausting for patients to have to do that, even if patients know that they are allowed to do that, but it's also incredibly time consuming for doctors and for their offices. And I think that it's really important to acknowledge that it is very time consuming for them. And that's partly where patients get involved to say, hey, how can I help? Or for myself, I'll contact my insurance company directly. And so the insurance company is often saying the doctor didn't do what they needed to do, and they'll just pass the blame back. But when a patient gets involved, you can just kind of cut through that and say, okay, let's just get to the bottom of this. I want to talk to a manager. I need this medication. What do you need that you don't already have? Another person at the bottom here says, eventually things usually go through, keyword being eventually. There's a lot of calling the insurance company and doctors and pharmacy before I can actually take what's prescribed. I always joke that here it's kind of good to have my British accent, because I think that the insurance company now recognizes my voice. It's like, uh-oh, here she comes. Is that Brit? Just give her what she wants because she's not going to give up. But honestly, it is really the squeaky wheel gets the oil in a lot of cases. And it is exhausting and it's not fair and you shouldn't have to do it. But when we fight, we often get it. And I know Lindsay put in a comment there about that we can appeal to, you can file a complaint with the state insurance agency. So there's a nice link there, headachemigraineforum.org/complaint. So this is another great example. Use your voice. It is powerful. One person here says, of course, my treatment plan has been limited by what my health insurance is willing to cover. Again, we can fight that and keep fighting it. Insurance companies often will get away with the denials because we don't appeal, but the more we appeal, the easier it gets. It really does. So here's a concerning one. Many physicians view combination therapy as unnecessary. And I think, again, that comes down to the shortage in certified headache specialists and just a lack of awareness for doctors who are not certified to actually become current with the most recent information. It's so important, and I think that that's a big area that we need to look at because most people with migraine, you're seeing your primary care physician, you're seeing your GP, maybe seeing your OBGYN, your ENT, and there are ways that they can be educated in headache medicine without going through, the time-consuming certification process. And then I think we're just gonna, on this particular page, we're gonna close with this sad comment, which is unfortunately for me, it comes down to cost and no time to fight it. And the reality is, if you're working, trying to fight insurance companies and be on the phone sometimes for hours it's just not feasible. You just can't do it. And so it is really stacked against you until you get so sick, you have to stop working. And then it's really hard to fight it because you're that sick and you have less money and your insurance has probably changed. So it's really a catch-22 that is, it's very, very sad.
I was just going to piggyback on that, Shoshana, because they count on that exhaustion. They count on that attrition, if you will, the wearing down. Every minute they stay on the phone with you is a minute they're not paying a claim. And so, this is where I think in particular there's strength in numbers, and why Shoshana helping to mobilize and organize to share this information with her community is so important. Individually, states have these state health insurance commissioners. Think of them as sort of watchdogs, if you will, that have oversight over the insurance industry in their state. And within their office or division of consumer affairs, because this is a consumer issue, you're paying for something, and are you getting adequate services in return? Let them be your advocate. And honestly, a lot of those health insurance commissioners cannot do something on a whack-a-mole basis, but they can recognize a systemic issue, right? So if there's a great example, there was a patient we talked to who kept getting, kicked out for not being able to see a UCNS certified headache specialist in Kansas. Oh, by the way, there were 0 in the state. And so, bringing something that egregious to the attention of the health insurance commissioner, they reverse that. But Shoshana helps to identify patients who might want to take action. I would just recommend, if folks are interested in having some help through that process, we can certainly walk you through that web portal. As Shoshana said, we dropped the link in there, but I think it's important that people feel empowered. But on the flip side, just an acknowledgement that for this community in particular, I would never disparage another disease state, but you have less of a capacity to know that you can sit on the phone for 4 hours or whatever, because you don't know if you're going to have an attack. It's really, it's really troubling, but it's also, I know this community is also highly persistent. And so we know that that's with a lot of squeaky wheels, to Shoshana's point. So we'll help you squeak, I guess.
Yeah. We love to help patients get squeaky. So it's good. You know, I'll tell people, and this is not a boast, but I have 100% success rate with my insurance company. But that has come from literally hours and hours, just the hours I can't even count on the phone with them. And I really think there must be some mark in my record now that says, just give it to her because she will not give up. And I, you know, I don't know if that really happens on the insurance level, but it feels like it because it's got easier. Now, I will also say that part of that comes from being with a good doctor. Sometimes we need to look for a different doctor. I know that that's easier said than done, but sometimes we do need to find a doctor whose office is willing to fight for us. You may have a fabulous doctor, but if their office is not doing the paperwork they need to do, right, Lindsay, then you may need to look elsewhere. And there are some other options. There are some telemedicine options now that, you know, that we can talk about another time. So just realize that you do have a right to optimal treatment, but we're going to have to fight for that. And as unfair as that may seem, it's just a reality, unfortunately.
Yeah.
All right, next slide. So this is just a thank you. We had 2 product sponsors for this particular survey. We love to give some giveaway goodies. So we had some pairs of glasses from Axon Optics, and we had a headache hat from Huggaroo. We had 7 people that won prizes. They were announced on the Migraine Meanderings website. And all those products should be winging their ways to people right now. But just a shout out to Axon Optics. Thank you for supporting this program, and to Huggaroo as well. Also to let you know, if you haven't taken advantage of it, Huggaroo is offering a 10% off any of their products on their website. That's huggaroo.com. You can use the code survey10 if you want to do it. Most people who know me know that I am a huge fan of Huggaroo. I have a neck wrap from them that I know a lot of people like ice. I like heat during my headaches. And so I put this heat wrap around my neck, and I love the Axon Optics glasses as well. So that's just a quick shout out to them. We couldn't do it without our sponsors for this program as well, because we like to get people excited about the survey and give you a little incentive to share your opinion.
So I think at this stage, because we're somehow right on track on time, Shoshana, which is wild and wonderful. Amazing. So we are moving to the Q&A, and I see we have a couple questions in the box. Before we pivot to that, wanted to mention that you know, we didn't discuss how is this survey going to be used, right? So Shoshana has sort of the mothership, if you will, of her group where she disseminates all of this great information. It's also going to get arms and legs with external groups and people who can make change. So we know that there's a group, and some of you might groan, but the Institute for Clinical and Economic Review, ICER, they do a value assessment and have a very close relationship with payers in terms of what therapies get on a formulary and whatnot. They're undertaking sort of an access report in November. We intend to share this information with them as gray literature that they can utilize. We also, HMPF will likely create an infographic or 2 to amplify some of this information on social media. But I know Shoshana has also created a survey report that really captures a lot of this data in one nice place. And so that will live on our website. It's already posted. So if you go to headachemigraineforum.org, and I'll try to drop in the link there and look under the resources tab, it's there now. But we also think that after the survey series is complete, and there is sort of this larger report that encapsulates these access issues in one place, you know, the step therapy devices, the ER data. I think that there really is an opportunity, Shoshana, for us to think strategically about sharing it with payers and health insurance commissioners as a communication, as to help them be put on notice as they're making formulary decisions. because, you know, at the end of the day, this costs them money as well, right? If payers are not paying for either preventive or optimal management of migraine disease, then they're going to have to pay for it on the medical benefit side through ER visits, et cetera. We learned that in the first webinar. So I think providing them a packaged document that talks a bit about all of this is something that we could do. So we'll pivot to questions now. We have some really great ones, and I might, Shoshana, put you on the spot too. The first one is a good one because it has an answer that we will rectify. I don't know, the person asked, per the demographics, did you capture any information on race and ethnicity? I don't know that we did, but we absolutely will in the future. So thank you for asking. Our next survey will include that information. It's being drafted right now. So we thank you for that question. I think sometimes we focus too much on things like age when we know for certain that there are disparities in this community and population, and particularly when it comes to access. I will say the HMPF Claims Project has a subset on combo therapy and step therapy, and we are looking specifically at claims data based on race and ethnicity. And so we will get that information and it will fill in some gaps there, but the next survey will absolutely include that. Question 2 from Simon Waters. He asks, do we have an idea of what is happening with people who don't respond to any preventives? Presumably a proportion are misdiagnosed or have other headaches as well as migraine. Shoshana, do you want to take that one?
Sure, I'll take that. I'm one of those people, unfortunately, or I do respond to preventives for a while and then I stop responding, which just happened recently. And honestly, I can never decide if it's better to not respond at all or to respond really well and then to have it stop. Because it's kind of like this roller coaster emotional ride that you're on. But it's just incredibly depressing. So just a shout out to anybody who, like me, does not really respond well to preventives. I think there was this misassumption, especially in some of the medical community that's not educated in headache medicine, that if you have migraine, if it is a good diagnosis, then you will respond to one of the migraine preventives, such as especially like the CGRP inhibitors. We hear it from patients again and again that the doctor's telling them, if you have migraine, then you're going to respond to this, and it's just not true. The clinical studies don't back that up. It's no one in the pharmaceutical industry is making that claim either. So it's interesting how some healthcare professionals have come up with that information, but it's not accurate. The reality is that migraine is complex. And there are different mechanisms involved in migraine. It's not just CGRP. It's not just inflammation. We have a whole load of new clinical trials coming up. One of the ones I'm interested in is the PACAP, that's PACAP inhibition, which also looks at inflammation, and it's been studied in other disease states besides migraine. So we know that it's not just CGRP that's involved in migraine. We also know that there are over 125 different genes that are involved in migraine, and the genetic research has only just begun. So that's just kind of given a little bit of the background. All I can say is that for people in my groups who do not respond to preventives or who have stopped responding to them or who can't tolerate them, because for a lot of us, we're not able to take certain preventives, then we just tell them, don't give up. You need to see a doctor, ideally, who's going to get creative with you, who's going to look at different options. I'm always like first in line to try something new, even though I know that it's not tested on people who have as complex a form of the disease as me. But I'm desperate. So, and a lot of us are desperate. So we just say, don't give up hope. Have a toolbox approach is one of the things you can do. So it could be that, a monoclonal antibody or one of the oral CGRP inhibitors may not work by themselves, but in combination with a medical device, in combination with lifestyle changes, with supplements, with maybe some biofeedback. You may not get total relief, but you may be able to get some relief. And so it's getting creative and pulling all these aspects together. I think this concept of one pill and done was the old way of treating migraine, and it's just not appropriate for so many people, but it doesn't necessarily mean you have a misdiagnosis. Having said that, you could be misdiagnosed, right? Or you could have another headache disorder type on top of that, which complicates things. You could have untreated thyroid disease, which could complicate headaches. You can have an autoimmune disease, which can cause headaches. You can have cervicogenic headaches. I'm not going to go through all of them, but there's so many different options. And I think that if you're one of those people that does not respond well to preventives or can't tolerate preventives, and you're just kind of desperate, you're not sure where you fit in, that's where it's important to find a headache specialist who is willing to get creative with you and who will not give up, who won't say, I've done all I can do for you. You know, we all need to hear a doctor say to us, I'm here, I'm not sure what to do, but we're not going to give up. We're going to figure this out together until we eventually find something. And so I think that's really crucial. And that's also where, you know, there are other programs out there that educate on different diseases, like the Migraine World Summit has this amazing summit in March where they talk about all these different things. So if you can't see a headache specialist yourself, you can listen to a headache specialist there, or you could go to one of the televisit options out there. I'm thinking of NeuroHealth or Code. You know, these are great places you can go to talk to a doctor, to help them, you know, to try to figure out what's actually going on with you. So a very long answer to a short question, but Lindsay, do you have anything to add to that?
No, I thought that was pretty comprehensive, and we're bumping up. We probably have about 5 more minutes. So I think we're going to get to the last 2 questions, and then Shoshana is going to talk about the next survey. So Doug Kane asks, any suggestions on getting assistance to pay for Nurtec on Medicare? He's on Medicare. He's not eligible for the Biohaven program, and the copay is $715 for a month's supply. So the short answer to that is CMS, which is the Centers for Medicare and Medicaid Services, which has oversight over those programs, definitely has a different relationship with what goes on formulary than commercial insurers do. It's an extremely difficult process to engage with CMS in terms of formulary coverage. So I wish I had better news. What I will say is that there's something actionable from your question, which is, you know, there's such a close relationship between migraine and disability that it really, for this disease state in particular, becomes a taxpayer, you know, efficiency or saving taxpayer dollars issue, right? Because if you can help prevent folks from going on disability and utilizing additional taxpayer funds that way, then I think that there's an argument you could make to, or certainly a letter that we could write to CMS Administrator Chiquita Brooks LaShore about, you know, providing better coverage for migraine patients so that they don't further chronify and end up costing taxpayers additional dollars. I think that's an argument well worth making. And so, Doug, we will think about that and probably take action on that. Our final question.
Let me just add something to that, if I may, real quickly. So Biohaven does have a patient assistance program that is applicable for people on government-funded insurance. So that is something to consider if your insurance, it's not only if your insurance denies it, but if the copay just makes it inaccessible to you. So that's a possibility. You can also, and Lindsay, you know more about this than me, but you can request a tier exception where you can actually have that, your medication shifted into a different tier with your insurance. Is that correct?
I believe that's right.
Yeah. So again, it's a lot of work, but those are some of the options that you may want to consider. And then of course, in 2025, we had this new law going into effect where people on Medicare, if you're maxed out at $2,000 a year, which still sounds like an awful lot of money, but it's a lot better than $715 a month. To me, 2025 seems an awful long way away, but it will get here sooner than we realize. So that's encouraging.
Yes. Our final question is from Debbie Bolduc. She asks, is there a governing body that certifies a headache specialist, or does this just mean a special interest in the area? And I will tell you, you know, there's the one that I think most folks or many folks are familiar with, which is the one I referenced, UCNS, which is the United Council for Neurologic Subspecialties. I can't say that with 3 times fast.
You did great.
Okay. So they do certify headache specialists, but I'll tell you, for like the state of Florida, I think there's only like 25. And you think that, you know, in a state like Florida with millions of people, you know, you can do the math and imagine that if you had a prescriber restriction, had to go to one of those people, it would be a long wait. And so that's a challenge. Also, I know for a fact that the American or National Headache Foundation they have a certificate in added qualification in headache medicine. And so that's sort of a program that a clinician can go through to get a certificate. And, you know, I think that for most doctors in medical school, they get like 1 or 2 hours at the most in neurology.
Right. And sometimes none.
Right.
Sometimes none.
In neurology, not just, not headache, but like that includes like movement disorders and other things. So it's just, it's a challenge in particular, Debbie, because if an insurer is asking someone, you have to have this prescribed from a headache specialist and a very specific kind, it becomes difficult, because for patients like you, waiting for a long time to see one of those folks is untenable, and then your disease worsens. It's just wholly inadequate. So I guess the short answer is yes, there are governing bodies, but as a community, we're kind of in many ways not opposed, but we don't like it when insurance companies place truly arcane limitations on prescribers. So
right, absolutely. And I would also add to that there are, I'm sure if you put headache specialists into Google, you're going to discover magically there's hundreds of them near you. They really are. So those are the people who just say they have a special interest, or they may not have a special interest. It could be that, sorry, my earbud just popped out. It could be that they just want to join patients who have migraine. They may have no education at all. So I actually am working on a website right now, headachodoctors.net, that has a full list of all the UCNS and AQH doctors in it. We update that 2 times a year, so it's as current as I think you're going to find. And that's a place where doctors cannot request to go on. They have to go through the certification process. Again, like Lindsay says, there are some states that just don't have any. There are less than 1,000 healthcare professionals who are on that database. And that is shocking. It's something that really needs to change. But again, that's why empowering the patient voice is so important. You can't just go to your doctor and expect that they're going to know how to treat you. Unfortunately, you need to have some of that information with you, go in and discuss it with your doctor or with your healthcare professional.
So with that, I think a next slide, Shoshana, do you want to tease out the next survey?
Sure. So this is a personal passion of mine, as people who know me know. I really feel that it's important that people not only have preventive medication and abortive medication, but they also have at least one medical device. And there are 5 FDA-cleared medical devices. 4 of them are pretty available on the market right now. We're looking at the Nerivio, the GammaCore, the Cephali, the Relivion, which is going through a relaunch, and then we have the STMS Mini, which is kind of I'm not 100% sure of the status of that right now. Some of them do preventive and abortive treatment. Some of them just do abortive. The ones that do just abortive are either considering doing clinical trials for preventive treatment or are already well into the way for that. So this is going to be a really exciting survey. Of course, we know that insurance companies generally do not cover them yet, but that's not 100% true. So if you think that that's 100% the truth, it's actually not, which is interesting. And for the VA, they often cover these devices. So we're going to talk about that next time. It's going to start on Monday, October the 3rd. Hope that all of you will participate in that survey so that we can learn more about people's experience with these devices, but also so that we can utilize this information, hopefully, Lindsay, and take it to insurance companies, because just from a dollar perspective, it makes more sense for them to cover a device that works sometimes than to keep sending people to emergency rooms and for additional treatment when they don't have what they really need.
That wraps it up for us, and we thank everybody for staying a couple extra minutes. I just want to thank Shoshana again, because this is really her life's work. She has the group that she engages with, and so we're just proud to be standing at her shoulder and being a partner on this. But look for some of the recorded information, the reports that will be posted online, and then that information from Shoshana about the next survey opening. And just thank you. Any closing thoughts, Shoshana?
I think that's it. I mean, back at you. I'm just really proud to be standing shoulder to shoulder with HMPF and with you. You're amazing people to work with. And yeah, it's a great example of how patient advocates can work together, and together we can make a difference. But we need you as well. So please keep sharing your voice, keep participating. We appreciate you. And thank you for being here today and for watching us.
Thank you.
Thank you.